Hello everyone. If I can have the first slide, great. Fantastic. And you have a mouse, excellent. So in this presentation, I hope will not be too provocative. I want to share with you what it is to be an academic and to spend 2 years in industry, where I had the great luck to be part of the executive at Accuray. And I realized a couple of things, which mean that sometimes we believe that we can just go to industry like a child, praying your parents and say, please help me for a solution, but we don't speak the same language. So that's what I would like to go through and maybe find a solution for the Middle East. So this is a time where I learned radiation oncology. Now you know my age, right? I was doing some fluoroscopy to treat a prostate cancer, and I treat, here you can see like 1200 cc of patients, but the prostate is 50 cc, so I treat 4% of cancer and a lot of normal tissues. And my therapist will bring me every day a gammography saying, doctor, are we good? And I would look at the film and would say, yeah, you're good, because with the eyes of the faith, I would see that. Nobody believed I was right, right? And honestly, sometimes I was pretty much off. But this is the way we're treating, and we're not that good. So physicists tend to complicate things, and I'm a physicist myself. And so came CT simulation, came the MLC to prevent the cereband, to protect the back of our therapist. And then the flat panel, same thing, to avoid the gammography, go faster. But with CT simulation, we invented the contouring to know exactly where was my prostate, so I was not off by so much. The MLC, the physicists make it more complicated. They invented IMRT, intensity modulated radiation therapy, and now we start to be precise, meaning we conform to the thing. And with the flat panel, we came to accuracy, meaning every day I can get a CBCT or a megavoltage CT, and I want to make sure, because I'm so precise, that my precision will be not off. I will not have a geographical miss, I can do the same thing. So great, this is excellent, but who's going to do the job? Well, it's our therapist. We delegate to our therapist, and this is what they do every day. We have a contour that we did, and on the day of treatment, they got a CBCT. They say, oh my God, we're off. So they do X, Y, Z correction, and the X, Y, Z correction, we delegate to them. At the beginning, they were calling me for every single treatment, but now I say, no, yeah. If it's less than family matter, you go for it, and then I give you the hand, you treat the patient. And they're happy, they do X, Y, Z, and pitch, roll, and jaw, and that's fine. So when do we really need hard therapy, adaptive radiotherapy? Well, there's days where our therapists will do the image-guided radiotherapy. They will try to do the X, Y, Z, and that does not fit, because my bladder will probably be a little bit bigger than expected. And instead of the prostate, I may have the seminal vesicle here, and my rectum is still off. So they are panicking, and basically what they are doing, they are paging me. I'm in the middle of a clinic, I don't know what to do. I call the physicist, he tries to figure out, and we say, stop the treatment, go back to CT sim. And on the day of today, oh, that's not supposed to go by itself. Okay, anyway, let me go back. So on the day of today, we tend to do a lot of adaptive therapy offline, and it's poorly organized. And so, a lot of people have organized you can find a lot of publication. For head and neck, you have to redo a CT sim after 3 weeks because they lose weight. Or when I treat an esophagus cancer, I know that if the guy has eaten in the morning, you will have 4 centimeters. They try to organize. But in fact, and that's when I start to work with my friend Per and with the team in Lund, we were pretty much convinced that in fact, it happened anytime. You never know when you have to do adaptive radiotherapy. And I was convinced also that probably head and neck is a great area where we have a problem, because we have so much critical structure close to a target, and the target can change, and you never know. And I get a lot of pushback from people like in the US, and I say, no, head and neck, it's easy, and we know exactly when we need to adapt it. Okay, deal, let's try. And we have our friend Andre, who did this very, very simple study that he presented last year at Astro. And at that time, Per, you had a tomotherapy with ClearRT, and I'm going to describe to you what is ClearRT. It's an improved imaging on the tomotherapy system. You had a research system, and with that, getting the image of the day, you were able to replan to see how often we are off and not off, and what would be the benefit of an adaptive. So you took 4 patients, base of tongue, laryngeal, tonsillar fossa, and another tonsillar. tonsil is not supposed to move, right? It's attached to the bone, so we should never adapt, right? And this is Andre thinking and speaking, as you can see at Astro. And basically what he did is, it's an in silico trial. He got the image from ClearRT, did a pseudo CT with a system that you've developed inside, redid the contouring, and look what will be the plan of the day if you apply the plan, and you replan, and then you look at a couple of how can you say, constraints. You look at all the constraints. Are they green? I fulfill my constraint. Are they amber? I fail them sometime. Or are they red? Meaning I really fail my constraint. And you count every day, if I would have not replanned versus if I replan, what is the best plan, correct? So what you expect is we're going to be good at the beginning, and the more the treatment go, the more we'll have to adapt, correct? So what is it for the upper pharyngeal cancer? Well, already on day one, adaptive plan is better. The first day, you did your CT sim a couple of weeks ago, and despite that, the first day is not good. And you see that a couple of days later, it's still good, then not good. You cannot predict when is adaptive better or not better, right? There, I'm pronouncing that well. Like supraglottic, the same, but became even worse over time. The orange, you see, you fail the initial plan more and more over time. Tonsil should be good all the time. Well, not all the time, but when, you don't know when. And so the other tonsil was quite good most of the time. So what I learned from the study that you have done, Per, in your university, oh, but you have the slide,
yeah,
Andre.
Oh
yeah, so that's for Andre, okay? That's very good. Yeah, say hi to Andre. No, what I learned and what we learned from your study is that you don't know when a patient needs adaptive or not, and it can almost be the first day. And the conclusion is we should have an adaptive for every patient every single day, because we give IGRT to a therapist, we should be nice with them. They should have the power and the ease to do adaptive every day. But adaptive, what should that be? That should be a high quality and fast daily image acquisition. Top quality should be 1 to 2 minutes max to get the image. Should be automated and fast segmentation. They should be able to control the volume. And the passing rate, meaning they are happy by the thing, should be 90-95%. Then they should be capable to have a daily dose recalculation that also should be fast. I put 2 minutes, but some software can do that in 1 minute. And then they should have a quality assurance like we do in 1 minute. The whole adaptive should be no more than 5 minutes. Otherwise, you cannot do that. You cannot impact on that. So there's a lot of machines out there that are claiming or positioning themselves onto the landscape of adaptive. You can see that there's an Merlinac. The Vure, unfortunately, the company is belly up, so we can remove it. There's a great machine. I saw that Noor is here. It's a great machine, which is the Alcyon/Ethos. And there's the Radixac with ClearRT that you call the CT-Linac. So MR claim they are superior. They are superior because seeing the soft tissue, you can see cancer. So segmentation should be, hi Vincent, you're late. So MR should be way better because you can see soft tissue, and then it could be easier to recontour. Yes, that's true. There's some couple of drawbacks for MR, especially because we don't have the Vure. The first is the electron re-entry effect, Laplace law. I have an electron going there, I have a magnetic field, I put the force. So every time I have a beam, for example, I treat a breast cancer, I've got a hotspot returning back. That may complicate a little bit the dose calculation algorithm or adaptation. So that's, I think, don't go necessarily there. Here's an example of a re-entry that you can see that there's a hotspot at the end. But I think that the real, in my opinion, the real drawback of Merlinac, this slide is from ISTRO 2022. Our friend Tobias Finazzi, he was fellow in Amsterdam, working with Ben Slotman, who's the past chair of the Thoracic Society. They tried to do the single fraction SBRT for lung using their Merlinac. It was a Vure. And what you can see is that for the single fraction, they took 2 hours to treat a patient because they get the image, they have to get the doctor to recontour, they have to get the physicist to recalculate, they have to do the QA, and after that they do They don't have motion control, so they need to do, how do you call that, they don't have breath hold, so they need to shoot the step and shoot, yeah, to do the thing. So 2 hours to treat a patient, I think that doesn't fit into a standard treatment. That's what I call the monster. So in my view, if you go to adaptive and you have to take more than a 15-minute slot, that does not fit. Varian came with a very nice solution. They really went to the field and to the landscape of adaptive by building around the Halcyon, adding some AI to facilitate the thing. So basically, they use AI as influencer. You can see here the image on an Halcyon before the hypersite. And with influencer, they are able to change the contour to make it closer to the reality. Then they also have an intelligent optimization, meaning they're able to shift the dose and change a bit the intensity of the beam. And eventually, they use with Moebius quality assurance. So not the measurement that you do in Sweden, but they do that. Last year, they introduced hypersite, and hypersite is a better image quality on the Halcyon and the Ethos. It may help, but I don't know at this point if it can help about the adaptive. They claim that the ounce field unit is better, but ounce field unit, you can see here the graph is going from -2,000 to +3,000. In fact, our ounce field units of interest for the tissue is more around 0 ±1. So I assume that if you get this curve and you really focus on around the 0, you may not have that accuracy in terms of ounce field unit. But I don't think the ounce field unit really change is really an issue about those calculations. When I was at Accuray for 2 years, I really tried to work on the adaptive solution and based on the ClearRT system. So ClearRT, what is it? You have tomotherapy. It's an helical system, so similar like a CT. And normally you get an image with a flat panel, so on a broad beam. So you have a lot of scatter. It takes some time to acquire the image. One of the ideas was to put just a window in front of the X-ray tubes. In doing so, you create a more narrow beam. With a narrow beam, you have way less scatter. Way less scatter, you take more time to acquire your image, but way less scatter, meaning that you're closer to a CT image. And the first image obtained in 2021 at Levenport, you can see on this patient, this is a patient which is a worst case scenario, very fat patient for a prostate treatment, so we expect a lot of scatter, and you can see that between the diagnostic and the ClearRT image, it's very similar, so it may facilitate the segmentation. 49 seconds of acquisition is not bad. So my plan was to connect this, exactly like Mohammed was saying, to the research system, because research is sort of very good at segmentation based on AI, very good at doing fast dose calculation, at evaluating. So we had a lot of work for over a summer about those images, and I did a lot of work getting some cone beam CT from the ClearRT and trying to do some adaptive. And here's an example. So imagine you have the patient, you just got on the bottom, you have the CT scanner. On the top, you have the ClearRT. And within 30 seconds, the plan of the day is recalculated. And you see that you're missing your seminal vesicle like in the previous case. So you can get the image, and if you ask, within 90 seconds, you can have a replan. And you can see here the DVH, which is wobbling until you optimize the thing. So between the image acquisition, which was 50 seconds, checking, which was 30 seconds, and recalculating, which was 90 seconds, within 2 minutes, we were able to get a new plan. And if you like the new plan because you see that you're fulfilling better your DVH, you can say, I'm going to select the adaptive plan. And so the next step, if I can pass on that, the next step was to check with QA, having all those constraints, and to have all the constraints going through and to see how many of them were amber, treat the patient but inform the radiation oncologist, green, you can treat, or red, stop the treatment, call the physicist or medical oncologist. So the system virtually exists, and you can say, I'm happy with the new plan, and then I can treat the patient this way. Delivery time on the tomotherapy was 2 minutes. So in silico, we did fulfill that for a difficult patient that need adaptation, everything was done in 5 minutes. That worked. Now, the plan, 2021, was to say, let's announce that at ISTRO 2021. It was in November. Then the first release will be in June 2022. Didn't happen. Engineer work, there was some problem of interfacing, didn't work. But the formal release was ASTRO 2023. ASTRO 2023, the company say, we're going to announce that this program is working, our ClearRT system associated with research, we can do adaptive in a remote of time. So here's Susan Winter, thank you very much, announcing the release. And in the release, she say, okay, thanks, we can transform with accurate adaptive suite. Fast, intelligent, automated, online adaptive solution using collaboration with Limbus. Wait a minute, Limbus, this is a company from Canada that is mainly doing AI for segmentation. And what about the research and all the things coming soon? Didn't happen. And I can tell you that the collaboration between research and accurate will not happen. So, high quality image we can get, automated, fast and reliable segmentation, not really. Daily dose distribution recalculation, not there. And fast quality assurance, not there. We do not have, on the present day, an industrial solution for adaptive, whatever they say. And this is where we should probably start to work ourselves, and that's what I'm trying to do at Sultan Qaboos. We could do image improvement. We don't need to get some fancy machine, sorry to say that. Motion management is probably the most important. Look at the Young paper. Young use here a phantom. On the left you have the CT. On the middle you have the cone beam CT without motion. On the right with motion. Motion is the number one source of artifact into your treatment. And to prove that, we have actually one of our staff who's doing a study. What you see on the left is a CT. In the middle is a CBCT with deep inspiration breath hold. And the other one is the right breast, no deep inspiration breath hold. And you can clearly see that all those patients have breast prosthesis. You don't see on the right one. So just saying that all our patients for better quality image should have deep inspiration breath hold might be a very simple solution. You don't need industry to do that. There might be some other thing. I have also some students working on doing some software, dual imaging, can we remove the scatter? Automated segmentation. There's a couple of solutions, and I think that probably deformable image registration is the way to go instead of recontouring everything from scratch. Like you contour the first day on the first CBCT, go from CBCT to CBCT and try to deform it on a daily basis. And there's some solution out there. There's industrial solution, but there's open source solution. You can see that the first solution on top, when you look at your prostate, over the, on a day where there was a lot of air into the rectum, we are way off. The other solution, which is free, come from Leiden, open source, is somehow better and can be improved. So there's a way to do that in a very fast way and without spending a lot of money. Now, planning, there's a lot of things we can do. We can review the planning parameter. We can calculate on a larger grid. We could ask our radiation oncologist, lower your constraints. You're going to do adaptive. It's going to be okay. Why do you want 98% to 98% of volume? It's going to take forever to calculate. You can go and losing a little bit of the constraint, go way faster. You can start with pre-class solution. For this kind of patient, I start and I just optimize. And then you go for quality assurance. That's not what I want to do. I'm very convinced that by very simple solution we can do. How can you remove this one? Sorry. So the beauty and the beast of adaptive radiotherapy, I think we must take control. My impression after spending some time in this industry is that industry has another purpose. Their purpose is to build machine to install for you and to make money. When I was in the company at the board, there was only one doctor. The doctor has never seen a cancer patient. He don't even know what is oncology, don't even know what's radiation oncology, because that's not their role. So we are very naive to believe that what we need, we're gonna get. They provide us phenomenal machine, but the way we want to go is to us, and we have to do it. I think that every little thing counts. If you can improve a little bit the imaging, improve a little bit the dosimetry, improving a little bit everything, we might be able to deliver adaptive within 5 minutes for a large number of patients. And I think that we also need to be smart. We have to select the application where we do. Starting with prostate might be smart. They don't move too much. You know, we can gain a little bit. We do ultra hypofractionation, so there'll be maybe a need. I think that we need to be self-reliant, modest, minimalist. We don't need to buy very expensive machine to do that. We need to work ourselves and to do it. Thank you very much.